Today, we are going to talk about adolescent depression and focus on like recent research and treatment effectiveness and clinically best practices. We are going to talk heavily from the TASA trial and other clinical data. So when you think about TASA trial, it's a treatment of adolescent suicide attempters. So it was a 6 months open label study where 126 adolescents between 12 to 18, all with unipolar depression and a recent suicidal attempt, participated. It had three arms, which was CBT alone, medication management alone, and combination of both. And majority of the participant, like 93 of them, received the combination therapy. So when you think about like key findings, the remission rate was 32% at week 12, means 32% got better. At 24th week, 50% got better. There was no significant relationship between type of treatment assigned and the rate of suicidal events. So while the treatments were effective in reducing depression symptoms, they did not directly correlate with preventing the suicidal behavior. So when you think about suicidal behavior or attempts, like what they found with was the risk factors are somebody with a higher self-rated depression, previous attempts, history of sexual abuse, family conflict led to more risk of suicidal attempt. Now, when you think about numbers needed to treat, you want to understand when in research, when you're doing comparing one to other treatment options, you want to know the number to treat and number needed to harm. Number needed to treat is number of patients who needed to be treated for one patient to benefit. So when you think about that number, fluoxetine, that is number 4. Means like if you treat 4 patients, one patient will get better. If you think about comparatively with statins for cardiovascular, it's 35. Phototherapy for jaundice is 281. So medication, Prozac helps a lot. So the lower the number, the more effective the treatment is. So when you look at compare, like a patient can come and say that, are these medications helpful? Or parent can question it. You can use this example to say that medications are very valuable. And numbers needed to harm. That is number, like sometimes you want to start Prozac on a patient and family will ask you a question. Oh, I heard that Prozac or Zoloft can increase suicidal risk. What are your thoughts about it? So numbers needed to harm plays a role in understanding that concept. That is, number of patients who needed to be treated before one will experience a negative effect. And that for SSRIs, it is 50 to 100 patients. So if you treat 50 to 100 patients, one patient may have a bad event. But if you look at statins causing cataract, it's 42. So you want to balance the like if there is a family history of somebody not reacting well to medications and all that, you can think about it. But overall, these medications are highly valuable and highly effective. So now let's look at clinical assessment and diagnosis. When assessing depression in adolescents, it's important to focus on functional impairment, ask about irritability instead of depression, build rapport by giving teens some control, assess sleep patterns, and screen for substance abuse and learning disorders. So sleep patterns, irritability is more important as a manifestation. Now, in terms of suicidal assessment, ask about peers' suicidal attempt, like anybody in your class attempted. Ask for access to guns. Pay attention to, your feelings, how your feelings about the patient. evaluate moodiness in terms of their irritability, duration, intensity, and impact on functioning. Okay. So other updates for some, recent research updates are they did Oros methylphenidate study, and 65% of the patient required 54 milligrams or higher. So when you're treating somebody with ADHD and you're giving Concerta, most of the patients on 54 and above do well. And insomnia treatment, alpha agonists like clonidine may be beneficial. Trazodone may be used in patients with anxiety and mood disorders. So hope that helps. Thank you.